Okay, good. Hi, everyone. This is Howard Mann. Welcome to the STR webinar. First this week will be Peter, is it Filev?
Yes.
From Emory. Okay.
Should I go ahead?
Let me first give you, hold on. Do you see a invitation to be presenter now? You should see it.
Yes. Should I just hit share?
Good. Okay. And let's see if we see your screen. And yes, we do. Okay, good. Thanks. Go ahead.
Okay. All right. Thanks, guys, for letting me present. My name is Peter Filev. I was a former resident of Brent and Travis, and then I stayed on at Emory as a part of the chest division. So start off by presenting a set of companion cases. They're both cardiac CTAs, and they're both post transcatheter valve replacements. So here's the first one.
Good.
It is this is a patient with history of aortic stenosis, and he underwent a transcatheter valve replacement in 2016, and then had persistent stenosis, symptomatic aortic stenosis, and they elected to do a valve-in-valve. So it's actually a TAVR and TAVR procedure, and you can see the two TAVIs there. They were post-op. They thought everything went well, and they were ready to discharge him, except he's having some chest pain. So they got this structural cardiac CT just to look at anatomy. And then as I started, first time I scrolled through it on the axial images, the thing that jumped out at me was this abnormality here. So I'd never seen anything like that, and just scrolling on the axials. Initially, my first inclination was this is part of the atrium, but then as I scrolled a little bit more, I noticed the wall seems continuous with the left ventricular wall. It's thick. As you narrow the window here, there's some low attenuation right there. And then as I played around with the multiplanar reformats, it became more clear to me that this is actually a aneurysm of the free wall at the left ventricle, right at the base. So I called it a submitral left ventricular aneurysm or pseudoaneurysm. And and I'm still not sure exactly what caused it. I had two theories. One is the patient had one is that this could be an ischemic infarction. The patient had a history of CABG, so I thought maybe one of his SVG grafts that had been previously stenosed and had to be stented, extending right to that region, supplying that region, became occluded. And then the other possibility I thought was maybe it was just some kind of iatrogenic injury, like they hit that wall there with a stiff guide wire and injured it and caused the aneurysm. So we can play also the cine. And so you can see the aneurysm there. It's right below. So this is actually the anterior leaflet of the mitral valve right there, and then this linear structure below is the chordae tendineae. And there's obviously abnormal motion of the abnormal motion of the posterior leaflet. So that's the first case.
Well, that's strange.
Yeah, something I'd never seen before. And then a few months later,
trying to do something about it.
I'm not sure what they did. I talked to them, and I was following the chart, and they actually discharged the patient, and then he never followed up. He never came back.
Okay.
I'm not sure. So the other case is a the case of a transcatheter mitral valve replacement. So this patient has a complex cardiac history. They already had a failed MitraClip repair of the mitral valve for severe regurgitation, and they had a follow-up annuloplasty, which also failed. So they weren't a good surgical candidate. So the team here elected to undergo this this procedure, this transcatheter mitral valve procedure, and it's kind of we have a new technique that was pioneered here at Emory over the last few years. It's called a lampoon procedure, and what makes it unique is that prior to deploying the transcatheter valve, they lysed the anterior mitral valve leaflet using electrified guide wires. The thought being that it decreases the chance of LVOT obstruction post deployment of the transcatheter valve. But unfortunately, in this case, right after the valve placement, there was severe they thought perivalvular leak on their echo, so they got this cardiac CTO. It's kind of a similar finding to the previous study. There's an aneurysm here, again at the base, and it seems like it's right under the mitral valve. And as I scrolled through, I could see that it was communicating with the annulus here. So in this case, I was actually in this case, I thought this was most like, since it's such close proximity to where the procedure was, I felt like it was most likely due to they dilated the valve, as I saw in the op report. So I felt like it was most likely an annular rupture from resulting from the balloon dilatation that caused it.
And the procedure that you described is called a lampoon procedure?
Lampoon procedure, and they actually published I think they've only done it about definitely less than 30 patients, but they published their outcomes in JACC. I think it was at the beginning of this year, actually.
Okay.
Yeah, and I think it's only been done at Emory and Henry Ford Hospital.
NIH.
In NIH.
Okay. Oh.
But actually, this patient, I think, ended up doing. They for the follow up, they went back in several days later, and they used Amplatz, 2 Amplatz plugs, and they plugged that aneurysm, and then they said that according to their echo, the perivalvular leak resolved, and the patient got discharged.
Interesting.
So,
good.
Yeah. Sure. Another thoracic case. So this case was shown to me by my colleague Eugene Berkowitz, and this is a patient with no significant past medical history, 41-year-old, and he over the past week he started developing severe shortness of breath, coughing, and was hypoxic on O2 sats. And so the findings here we thought were kind of non-specific. There's patchy bronchocentric ground glass. It seems pretty diffuse. Both lung bases and apices are involved, and then as you look at the lungs on the coronal, you can notice that there's essentially widespread central lobular ground glass nodularity that's bronchocentric. Then we got some additional history, and we found out that he had been vaping CBD oil for the past 2 or 3 months to relieve back pain. So what we came up with was that this was a, so he actually had a normal chest radiograph from a few days ago. So based on that, we concluded this was a most likely a acute inhalational lung injury associated with the vaping. It doesn't, the imaging pattern isn't entirely specific to fit one specific category of acute lung injury, but we thought it could be just a combination of diffuse alveolar damage, organizing pneumonia, and kind of a chemical pneumonitis from the inhaled oils and hydrocarbons. I just wanted to see what the rest of the group, what you guys think about that, if you've seen.
Yeah, definitely consistent with that. Yep, definitely.
Okay. And I can show one last case. It's a vascular case. So this is a patient with a type B intramural hematoma, which was repaired with a endograft in the descending aorta. And I actually saw this case on my call shift first thing in the morning on the weekend on a Saturday morning, and I didn't agree with the prelim, so I called the surgery. I called the surgeons that had ordered the scan. When I called them, they were preparing to. They already consented the patient. They were preparing to take them in for repair. So the patient had the intramural hematoma repaired previously, but then while still in the hospital, a week later, he was having new chest pains and some non-specific symptoms. So they'd ordered the scan and they were preparing to take him in for an emergent procedure to extend. They thought this was a endoleak, and they wanted to extend the graft. So I told them I thought this was basically the repaired intramural hematoma, and then the contrast that you can see outside of the confines of the graft is actually intramural blood pool, or also known as branch artery pseudoaneurysms, which don't require further intervention and aren't necessarily associated with increased risk for progression to dissection or intramural hematoma. And then they were quite skeptical with me, and but I was able to convince them. And then they of course ordered a very short-term follow-up the following day of the same scan, and it was completely unchanged. And then another follow-up a month later was essentially unchanged. But I thought this was an interesting case just because it kind of highlights a concept that people that don't specialize in reading vascular studies can find confusing, is that it doesn't necessarily mean it's an endoleak just because there's contrast outside of a graft.
Peter, can you just double click on that to zoom in, show it by itself, the one on the left?
Yeah. Oh, the one. Yeah.
And then just use like Command S to zoom in, and zoom in on that, and let's see if we can trace that. If you just use Command S to zoom in on your keyboard, make it big, it should mag up, or use a zoom function.
Unfortunately, Command S was not working for me.
There you go.
Okay.
And then let's see if we can trace that directly to.
Yeah. It might be coming from a bronchial artery. At least part of them are, and then if not a bronchial artery, from intercostal arteries.
Yeah, intercostal. In other words, if you just zoom in and then zoom in quite a bit, again, if you can. So, okay, now just go slowly, because I think I could see an intercostal artery maybe coming out of the bottom of it. Right there, just pan down, bring it to the center if you can with the pan function.
bad function, yeah. The other way.
Yep. Now scroll through that slowly until you see an intercostal artery, right?
Yep. Yeah, exactly.
I think so, yeah. Because then you're super confident. Yeah, but otherwise, there actually may be two of them. Maybe, I can't tell. But certainly
Yeah.
consistent with the so-called pseudoaneurysm involving an intercostal artery blood pool, right?
Right, yeah. Yeah. Yeah, to specifically write an impression, no endo leak. So,
There you go. There's the artery right there.
Yeah.
Yeah, very good. Yeah, very good.
And that's it, guys. Thanks a lot.
Thank you. Okay, great. Let's see. David, do you have any cases this week?
I have a couple.
All right.
So I'd like to show you a young woman, I think she's in her 30s, who switched her vaping product a couple of weeks before and then got short of breath to the point that she was having difficulty going up 1 or 2 flights of stairs. And she has this patchy ground glass abnormality in upper lobes, just a little bit in lower lobe down here, mostly upper lung, and just a little bit in bases here, also involving middle lobe. And this was the second case of vaping related injury in King County, which is a county where Seattle is located. There have been, I think, 8 in the state. I don't think we've had any deaths in Washington state from this, but this is presumed vaping related lung injury. And she had a follow-up chest radiograph about 10 days later, and it shows everything's nice and clear, but you know, that subtle ground glass could be missed on a chest radiograph. So a follow-up CT would be definitive in showing clearing. The chest radiograph suggests that it cleared, but it's not 100%. So another vaping, this is our first in our hospital system, in the UW hospital system. This is one of our affiliated hospitals had this patient. So vaping was out there. Howard brought our attention to this first, but now everybody knows about vaping. Shouldn't vape. And it was a THC containing product that she was vaping. Okay, here's a person with some shortness of breath and altered mental status. And this person has a history of stem cell transplantation and then has been on some immune suppression and has this radiograph here showing very low lung volume. She had altered mental status and she had a head CT. I'm told that this is showing some low attenuation lesions scattered around, and I'll take their word for it. So we have these low attenuation lesions, and then she had abdominal imaging here showing low attenuation liver lesions. This lesion was biopsied here. There was a needle biopsy, and this is PTLD. So at the same time, she has these smooth lung nodules. I'll show those to you better on a follow-up exam here. So here's our chest CT that shows these nodules. And the first consideration for somebody who is immune compromised by Rituxan and other things would be fungal infection, but these really don't look like fungi in terms of their basal predominance rather than their mid-lung predominance. The associated air bronchograms, the large number of lesions here, the fact that some of them are getting fairly peripheral and stuff like that, and this one's, for instance, right on the bottom surface of the lung. So I believe that the lung lesions are also PTLD. When they sampled her CSF, they got abnormal lymphocytes with a clonal population consistent with PTLD as well. They were relying largely on specimens from the outside hospital. So I think that the PCR for EBV is still pending or something like that, but the findings are consistent with PTLD in her brain, her liver, and presumably her lung, although they've not sampled the lung lesions. So the plan is to follow her up radiographically with repeat CT scans after treatment for PTLD is undertaken. So lung nodules in this case, I think, are PTLD rather than fungal infection. And we have PTLD documented in other tissues, liver and in CSF. Okay.
Yep. Good.
So this is one of the few cases of PTLD in the setting of stem cell transplantation that I've heard about. I don't have any previous ones in my own database. I've not been shown any. So PTLD is a known complication. All it requires is enough immune suppression that the EB virus is set free and can do its job in converting lymphocytes into lymphoma. So it is a known risk in stem cell transplantation, depending on immune suppression and stuff like that. Because she was immune suppressed with drugs, she developed PTLD. So it can be seen in the setting of stem cell transplantation if there's enough immune suppression. Okay, those are my cases.
Thank you. Okay, I will show you this one. And before I show you the images, I'll give you the context. So this is a patient with a history of melanoma and treated melanoma. And in this context, she had her usual surveillance imaging schedule, that is a chest CT and an abdominal CT, when they come back to the clinic. And she's 40 years of age. And it turns out that, and I'll just show you a prior CT from April, that her lungs look fine. We ascribe this opacity, by the way, probably to some regional radiation therapy. But when she came back to the clinic, she was indeed symptomatic. She did complain of respiratory symptoms, and I'll show you some more about that in a moment. So the context was treatment for melanoma and surveillance imaging. And of course, this is a surprise. Very interesting opacities in the lower lung zones, where we have subpleural sparing and a really interesting curvilinear appearance, I don't know why, to the opacities, the ground glass opacities that are present in the lower lung zones. But given the context of what we've just talked about, and our threshold for thinking about this has changed, albeit not usually in a 40-year-old person, I think someone got a history that she didn't have clear-cut findings suggestive of an infection. We did ask actually about vaping. And sure enough, there we go. Whoops, let's see what that is. Okay, sorry about that. Go back there. Can you still see my screen properly?
Yes.
Okay, so there you see the history. So she did have 10 days of fever, body aches, temperature. She took some Tylenol and ibuprofen. But because we prompted them to ask her about vaping, they went back and asked her about vaping. And as you can see there, they got that history. They actually determined that she'd been using a new vaping product called Rove Tangy Sativa. So that's kind of a THC concentrate. It's got some CBD in. This is what this item looks like. So it's a oil pen basically. And it's got some cannabis in that particular thing. So this was a surprise. We didn't expect to see this in this particular context. A 40-year-old being imaged for melanoma, but symptomatic. So that was really an interesting case. And I don't know whether they would have thought about it if we hadn't prompted them to ask her. But that's the provisional diagnosis. So 3 of 3, third of 3, right? For this week already.
Wow.
So one from David, one from Peter, and a slightly unusual one from here, at least in terms of the context. But otherwise, the findings are very consistent with that. So it's out there, as David said. Okay, let me show you this one. This one is just a very nice example of this interstitial lung disorder, and because I have a lung biopsy report, I'll show it to you. So let's go back in time, initially starting in 17, at least a CT from 17. This is what this patient's lungs looked like, particularly in the lung bases down here, where we have very extensive, confluent, ground glass attenuating opacities. There's one very small apparent cystic space there, but otherwise we do not have cystic spaces, and we certainly don't have findings to suggest traction bronchiectasis or subpleural traction bronchiolectasis or any hint of honeycombing, of course, but just bibasilar, extensive ground glass attenuating opacities. So that is 17. Let's go forward to, so this one is July of 17. Actually, she had a fair amount of imaging back in July. So let me show you what it looks like now. And I'll go to a lung window. We do not have thin cuts, but basically it has progressed some. There's a lot more ground glass attenuating opacity there. But again, there's a conspicuous absence of traction bronchiectasis or traction bronchiolectasis. I think some of these regions are maybe areas of spared lung rather than actual cystic lung or cystic spaces, as best I can tell. So certainly this is very consistent. I think we would all agree with nonspecific interstitial pneumonitis, and particularly cellular nonspecific interstitial pneumonitis rather than fibrosing. And here is the corresponding path report. Notice that she does not have a connective tissue disorder. She does have a history of Raynaud's disease and dry mouth, so one would think of scleroderma. But let me show you a little bit more of the path report, which is a really nice description of a cellular nonspecific interstitial pneumonitis. So there is diffusely abnormal cellular variant, some organization and fibrosis, but not particularly striking, going along with the CT findings. The pathologist, of course, thought about a connective tissue disorder, and they also, because of plasma cells, evaluated for the possibility of IgG4 related disease, which is not present. So a really nice correlation between this nice pathologic description and the imaging findings we see. So at this point, idiopathic cellular nonspecific interstitial pneumonitis. All right, let me show you this one next. This one is nice to look at because it's a before and after. So let me start off here. This patient, I don't know when the pulmonary hypertension was initially diagnosed, but she had a diagnosis, or eventually had a diagnosis of pulmonary hypertension. At this time, she's got an esophageal hiatus hernia. I don't know what these basal lung opacities represent. They may just represent areas of atelectasis. Certainly in the context of pulmonary hypertension, without additional history, one might think, particularly if the vessels appear very abnormal, of findings of CTEPH, at least in the sense of peripheral infarcts, perhaps. So that goes back to 2018, last year. And this is also then. Okay, so let's go forward to March. And certainly the basal lung opacities have resolved. One can reasonably speculate that these might be spars from episodes of pulmonary embolism, or an episode, and represents small infarcts. There's the hernia. And then I'll show you we have super typical findings of, let me actually bring in this one, which is less noisy, of CTEPH. So dilated pulmonary artery, but as I scroll down, we'll look for webs and stenoses and other vascular findings. So let's go down, and first on the left side, here is a nice web in the left lower lobe pulmonary artery here. Let me just try to bring that out for you. And then perhaps the most dramatic change is looking at the right interlobal pulmonary artery, and as we go down, we just basically lose the pulmonary artery, and then we have no vessels here, no contrast opacified vessels there. So that's very abnormal. And I'm trying to remember if there were other findings of CTEPH, but that's pretty dramatic. Here is perhaps a luminal abnormality that goes along with CTEPH, perhaps there as well. So this patient has severe pulmonary hypertension. We do have one surgeon here that does pulmonary endarterectomy, and that was performed. So let me show you now the before and after. Sorry, that's not what I wanted to do. So let me show you an exam from March on this side. Sorry about that. Oh, before I show you that, let me just show you pretty typical findings on the lung perfusion scans. So let's see if I have the conventional perfusion abnormality. And you can see very extensive abnormality, particularly in the right lower lung. And here is the SPECT CT, and you'll see substantial abnormalities of perfusion, particularly in the right lower lobe, but also in the left upper lobe. So that was done close to that. So then she went to surgery, and let me just pick up the one that I have here, which is this one. And this is the most recent one. So let me go back to, for example, here, where we have dramatic occlusion of pulmonary vessels here. And you'll see that that opens up surprisingly nicely. So here we are, and the surgeon really opened up that area, particularly that area, really nicely. So we have nice perfusion there. And other areas were also opened up. So let's see what we have here. Here you can see that some excerpt from the op report. They saw the disease, they went in, they did endarterectomies. Even in the operating room, her systolic pressures diminished. This is preoperative, showing the pulmonary artery pressure. Here is a summary of the before surgery cardiac ultrasound, and then the after surgery cardiac ultrasound, showing expected findings of diminished pulmonary hypertension and intracavitary pressures. This is one of the nicest ones I've seen, in which the webs, the stenoses, and particularly the right lower lobe vessels really opened up nicely. I wish I had pictures of what was taken out there, but I imagine you took out a lot of organized thrombus during the endarterectomy procedure from the right lower lobe right there. That's pretty dramatic.
Howard, could you see the left upper lobe abnormality that was?
Oh, let's have a look. Let me bring up the pre and the post for the left upper. Let's compare that. So let's go back here. Oh yeah, so let me show you this. I forgot about that. So here, looking and trying to find the left upper lobe pulmonary artery before, it's really hard to find anything right there. So let's go here, and we can see here we have it right there, whereas before we did not. So again, just to mag that up, that's actually a nice finding too.
Mm-hmm.
So before and after. So before, there's really just a nubbin here, nothing more than that.
Yeah. Just a hint.
Right there, just a hint of a vessel there, and
Right.
it opens up really nicely after the surgery.
Her pulmonary artery caliber is decreased quite a bit.
Yeah, and the main pulmonary artery caliber is also diminished. Yeah, so that's a very nice result.
Absolutely.
Yeah. Let's see if we look carefully whether we can see that, when we look at the lung window, whether we can see that the perfusion's better and the caliber of vessels is better. So scrolling through the left upper lobe before and after, I can see some vessels are obviously bigger and more blood flow. Let's go down here to the right lower lobe before and after, particularly down here, say. Well, one can see some small changes in terms of perfusion, but nothing super glaringly obvious down there. Okay. I do have another one. Okay, this one. This is a patient with pulmonary emphysema. She was referred for the possibility of lung volume reduction surgery. Now, that can be done surgically, as you know, in selected candidates who meet the criteria for lung volume reduction surgery. And one of the criteria is a very heterogeneous distribution of pulmonary emphysema in the upper lobes typically compared to the lower lung zones. But they can also do this medically now. So by means of endobronchial valves, one can do a transbronchoscopic medical form of lung volume reduction surgery. And I don't know exactly why, but she did end up going to the pulmonary physicians, not the surgeon, and they deemed this that she was a candidate for that, so they did the procedure. Let me just give you a feel for the distribution of emphysema. Obviously very severe, very extensive, large bully in the upper lung zones, whereas the lower lung zones look pretty good. The other thing that they look for prior to placing bronchial valves, in addition to the distribution of the emphysema, is the completeness of interlobar fissures. And you can look at that on thin sections. But if the interlobar fissures are incomplete, particularly if they're substantially incomplete, they may deem that person not suitable for the transbronchoscopic lung volume reduction surgery because airflow will just go from the other lobes into the upper lung zones. But she was deemed a candidate, and they did the procedure. And the next radiograph I'm going to show you is an image obtained just after, within about an hour, I think, but really close to the time of surgery. Excuse me, the placement of the valves. So first you can see that they put in a total of 3 valves on the left side. And we have findings of substantial upper lobe volume loss. And the finding that I initially went by, because I was really fixated on this, is the fact that if you look for pulmonary vessels down here, they really stop right there. And down here, we do not see vessels. So I'll try to bring that out. But initially, I did not perceive that. So certainly we have a lot of volume loss. Then she was imaged after that, which confirmed that we do in fact have a pneumothorax or pleural gas that's down here. So that is 26th. Here's an image from the 20. Let me see if I have one before that one. I'm not sure that I do. Let me just show you another image that we had on the 26th. So here we have left upper lobe collapse. And I thought I had the lateral because this is indeed a fluid level in the pleural space. So we have pleural space gas, and we do have some fluid in the basal left hemithorax. And this is the 27th when they put in the chest tube. So again, here we have CT after that. I'm not quite sure why they do the CT, showing the gas there. There you can see the persistent left upper lobe atelectasis and the endobronchial valves. So this is, I think, a very nice example of the entity of pneumothorax ex vacuo. That is, this is probably nitrogen rather than air, and it's a direct consequence of the acute left upper lobe collapse that is present, not because the visceral pleura is breached. I think the patient was rather symptomatic, so I'm not entirely sure why they put in a pleural drain, because if you look at this article, and this one, as far as I know, is the classic article about pneumothorax ex vacuo, is that you don't need to put in, and really shouldn't put in, a chest tube, because the ex vacuo pneumothorax is a consequence of the volume loss, not because of the breach of the visceral pleura. So there was no plausible alternative explanation. They just worked in the bronchial tree. There was no reason that there should be a visceral pleural disruption. And this volume loss has persisted. It really isn't getting better. This one is from the other day, and you can see persistent substantial left upper lobe volume loss, residual pleural air. So they're talking about actually maybe taking out these valves. Maybe I'll just take out one, hoping this lung will expand better. There's still some pleural fluid in the volume loss that you see there. So undoubtedly pneumothorax ex vacuo in this context. David, you like that one?
I like it, although, you
Are
know,
you skeptical?
how do we know? How do we know there wasn't some rupture of the pleura or something like that? So
I think that they were working entirely endobronchial, so it's a little hard to conceive that just working in the bronchial tree you would do that, I think.
Okay, well, be nice if they would sample the gas and show that it's pure nitrogen rather than 80% nitrogen. So a lot of cases have been, you know, they've been presented around here as examples. This is the most clear-cut example, I think, of that possibility, ex vacuo. So
I think it is, yeah.
Yeah.
So we'll see how she does. I'll let you know in follow-up on how she does and whether they perhaps actually go in and maybe remove one or more of these to allow that left upper lobe to collapse. I don't know why it's remained so atelectatic, even with the valves in place, but it is.
there's probably a nice complete fissure, and they got all three. They got, you know, all the three segments for that upper lobe. So, you know, and then maybe there was a little bit of mucus or blood that sort of sealed everything and kept the one-way valve effect from working. They put them in the right direction, right? They didn't put them in backwards or anything.
Oh, no, I don't think so. No, they're pointing in the right direction in that sense.
Got it.
I don't think one can actually deploy them in the wrong way. You have to get them in with the point in the right direction, and then you inflate them, and then you see these things inflate.
Okay.
Under bronchoscopic vision. Yeah. So that's my diagnosis so far, and then I'll let you guys know what happens. Alrighty, everyone, that's it for this week.
Thank you, Howard. Thanks for running everything.
Peter, for joining us, and feel free, of course, to present in the future. That'll be great.
Thank you very much.
Thank you.
Thanks, everyone.
Yes.
Okay, bye-bye.